Welcome to this explainer. Today we're doing a deep clinical dive into two highly distinct pediatric conditions, external hydrocephalus and X-linked hydrocephalus. We're skipping absolutely zero details here. My goal is for you to master these clinical concepts completely just by hanging out with me for this session. So let's get right into it. Here's the game plan for today. We'll start with understanding external hydrocephalus, then move into differentiating and diagnosing it. After that, we'll cover treatment and management. Then we'll pivot to an overview of X-linked hydrocephalus and wrap the whole thing up with genetics and pathophysiology. All right, Section 1, Understanding External Hydrocephalus. Let's jump into a condition that is honestly notorious in the medical literature for having way too many names.
Seriously? The terminology for this single condition is just a mess. Depending on which textbook you're reading or which attending physician you're talking to, you might hear it called extraventricular hydrocephalus, benign subdural collection of infancy, or BESS, which, by the way, stands for benign enlargement of the subarachnoid space. Some even call it a subdural hygroma. It's a lot, right? But for the sake of absolute clarity in this explainer, we're just going to stick to one term, external hydrocephalus.
So what is it exactly? At its core, external hydrocephalus is defined by enlarged subarachnoid spaces. This extra fluid accumulation happens primarily right over the frontal poles of the brain. And here's a key takeaway. It's overwhelmingly a condition that pops up in the very first year of life. Now, the clinical presentation is highly specific, and you really want to lock these points down step by step. The most obvious initial sign you'll see is an abnormally increasing head circumference in the infant. But, and this is a massive but, when you actually image the brain, the ventricles themselves are totally normal, or maybe just mildly dilated. You'll also spot enlarged basal cisterns, along with a widened anterior interhemispheric fissure. Clinically speaking, the infant might show a slight delay in motor milestones. Honestly, that's often just due to the sheer physical weight of their larger head. Aside from that, they're typically asymptomatic. So why does this happen? Well, we don't entirely know. The exact etiology remains pretty unclear. The leading theory right now is that there's a temporary defect in cerebral spinal fluid resorption, meaning it might just be a specific variant of communicating hydrocephalus. Beyond that, we do know it's strongly associated with certain craniosynostosis, especially plagiocephaly. It can also show up after traumatic events, like an interventricular hemorrhage or a superior vena cava obstruction. Okay, moving on to Section 2, differentiating and diagnosing. This is where things get really interesting because we have to figure out how to tell this relatively benign condition apart from something far more dangerous. This is where your diagnostic skills really get put to the test. You absolutely have to be able to distinguish benign external hydrocephalus from symptomatic chronic extraaxial fluid collections. The biggest, most pressing differential here is a chronic subdural hematoma. Unlike our benign EH, a hematoma is dangerous. We're talking severe symptoms here, seizures, vomiting, terrible headaches. And most alarmingly, it can be a direct result of non-accidental trauma. Basically, child abuse. Missing this distinction, yeah, it's just not an option. So how do we make that call with absolute confidence? The definitive trick in a clinical setting is looking for something called the cortical vein sign on an MRI or a CT scan. It's a real game changer for diagnosis.
Let's break down the mechanics of this. In external hydrocephalus, the cortical vein sign is present. What this means is you can literally see the cortical veins floating outward. They extend right from the surface of the brain, through the fluid, all the way to the inner table of the skull. Now contrast that with a subdural hematoma, where the cortical vein sign is absent. In that case, the fluid collection essentially acts like a weight, compressing the subarachnoid space and forcefully pinning those veins directly flat against the surface of the brain.
Right, let's jump into Section 3. Treatment and management. Once you've nailed the diagnosis using that cortical vein sign, what's next? Let's talk about how we actually manage a confirmed case of external hydrocephalus in the real world. The best part of this diagnosis is the reassuring news you get to deliver to the parents. External hydrocephalus is largely self-resolving. The infant's anatomy usually compensates by around 12 to 18 months of age, and the fluid collection clears up entirely on its own by age 2. And yes, all of that happens without the need for any surgical shunting.
Because it resolves on its own, management is strictly conservative. It's basically a 3-step protocol. Number 1, monitor the infant with serial ultrasounds or CT scans just to ensure there's no abnormal ventricular enlargement happening over time. Number 2, and this is a big one, you have to emphasize to the terrified parents that the fluid space they are seeing on the scan is not cortical brain atrophy. Their child's brain is developing totally normally. And number 3, because of the enlarged head, you'll want to advise parents to periodically reposition the infant's head during sleep to prevent positional molding.
Now, while conservative management is the golden rule here, there are a few extremely rare instances where you might consider surgical shunting. For example, if you tap the fluid and it turns out to be bloody, which, again, is a massive red flag for non-accidental trauma. Other than that, intervention might be on the table for severe cosmetic reasons, like extreme macrocrania or significant frontal bossing that could really impact the child's quality of life down the road. Let's switch gears a bit to Section 4, X-linked hydrocephalus overview. We're going to contrast what we just learned with a much more severe, genetically driven condition. It really rounds out our overall understanding of pediatric hydrocephalus. So, unlike external hydrocephalus, this condition is strictly inherited. And because it's X-linked, it's expressed almost exclusively in males. It is passed down by phenotypically normal carrier mothers. This creates a very classic genetic expression pattern, one that typically skips single generations within a family tree.
To put this into perspective, it is incredibly rare. The precise incidence rate in the general population is somewhere between 1 in 25,000 to 1 in 60,000 births. But when you look specifically at pediatric hydrocephalus cases, it accounts for about 2% of them. So while it's rare overall, it's definitely clinically significant. Thanks to modern genomic mapping, we've actually completely isolated the specific genetic culprit for this condition. We know exactly where the error happens. It's been pinpointed to a mutation located right on the XQ28 gene locus. Which brings us to our final section, Section 5, Genetics and Pathophysiology. Let's put this under the microscope and zoom in on the exact cellular pathophysiology happening right there at that XQ28 locus. That XQ28 mutation directly messes with the production of a specific protein called L1-CAM. Now, L1-CAM is a membrane-bound receptor, and it is absolutely vital during central nervous system development. Its main job? Guiding axonal migration to the correct target locations in a developing brain. It pulls off this highly complex routing using integrins, cell adhesion molecules, and the MAP kinase signal cascade. It's a beautiful, intricate system when it works. But when this gene expression is abnormal, that cellular cascade completely fails, and the consequences are pretty devastating. First, you get poor differentiation and poor maturation of cortical neurons. But this isn't just a microscopic problem. It snowballs into massive macroscopic anatomical defects. The most severe of these is the bilateral absence of the pyramidal tracts. And as you probably know, those tracts are absolutely crucial for voluntary motor control. There's actually a very clear, direct connection between the specific genotype and the resulting phenotype here. If the mutation causes a total loss of function in the cytosolic domain, you get severe L1 syndrome. But if the genetic mutation still manages to retain the expression of at least some functional protein embedded in the cell membrane, the patient will present with a milder form. Basically, the severity of the syndrome entirely depends on just how much of that functional membrane receptor survives the mutation. Which leaves us with a pretty profound question to wrap up on. As we continue to master our understanding of these specific genetic pathways, knowing exactly that the XQ28 locus and the L1-CAM receptor are the culprits here, how close are we to catching and maybe even correcting these genetic missteps before the very first signs of developmental damage occur in utero? It's a wild, fascinating frontier for fetal medicine, and it really highlights exactly why mastering these deep clinical mechanisms matters so much. Thank you so much for focusing in with me on this explainer today.